B. I'm just looking to see who here is here to correct me. I think I saw Ashwin earlier, and I see Dave. I don't know if it's Chloe. Anyway, so I thought actually, so I was reviewing the data from Hep B reactivation, which we'll get to from IAS, and as I was doing it, I also just sort of was thinking a lot about hepatitis B and the recent hearings about vaccination and concerns about vaccination in children, and as part of my ongoing campaign to just have sort of like calm information, I thought I'd just go over a little bit about the history of hepatitis B vaccination in our country specifically. So prior to 1982, there were about 200 to 300,000 acquired hepatitis B cases per year, including 20,000 children per year. In 1982, the ACIP recommended hepatitis B vaccination for groups at high risk. This included men who have sex with men, people with injection drug use, heterosexual individuals with multiple partners, healthcare workers, staff at institutions for the disabled, end-stage renal disease, recipients of clotting factors, and then some endemic populations like Alaskan Natives and Pacific Islanders, as well as people in correctional facilities. So that was the recommendation in 1982. By 1989, it was clear that vaccination was not reaching all people at risk, and I think it was estimated that more than half of people who acquired HBV were not people who were identified to be at high risk. And in 1991, there was a strategy developed to eliminate hepatitis B transmission in the US. And this was highly dependent on a couple of principles, including childhood vaccination, vaccination of adults and adolescents in high-risk populations. And then in 1995, the ACIP recommended routine vaccination of all adolescents ages 11 to 12. And in 1999, this was expanded to all unvaccinated children less than 19 years of age. And so what this figure here on the right is, and this is from an MMWR from the early 2000s, summarizing the impact of the policies that were put in place, including universal infant vaccination, which is indicated here by the heavy dark arrow, is that acute hepatitis B here in the blue solid line declined dramatically as the vaccination coverage rate increased. You can see this like beautiful X that's created by the overlapping of this highly effective policy. So between 1986 and 2000, the rate of acute hepatitis B in children ages 1 to 9 declined by more than 80%. And between 1983 and 1995, the rate of hepatitis B in healthcare workers declined 95%, such that healthcare workers with adequate vaccination are now at the same risk as the general population. Among Alaskan Natives, another good case study to see the impact of these vaccination policies. In 1994, the prevalence of chronic hepatitis B in children less than 10 years was 0 versus 16% in the age category just above that, between the ages of 11 and 30, suggesting that that children are being protected by these vaccination policies. So perinatal vaccination success. So in 84, there was a recommendation for screening all pregnant women in high-risk groups and then administering post-exposure prophylaxis, which included vaccination and also HBIG, or the hepatitis B IG, for all infants born to Hep B surface antigen positive mothers. However, there were studies early after that recommendation that showed that 35 to 65% of hepatitis B surface antigen positive women were missed in screening during pregnancy. So instead of using risk-based screening, we moved to universal screening in 1988. And then with government programs to promote perinatal screening and prevention, we had really good success. So in the year 2000, there were 10,192 infants born to hepatitis B surface antigen positive mothers. 90% of them received HBIG and the Hep B vaccine prior to hospital discharge, which is awesome. And 71% completed 3-dose vaccination series at 6 to 8 months. So doing really quite well. So just to also put in context, like, oh, okay, this sounds like the greatest success story ever. So what else could be happening? So concerns about vaccination. So in the mid-1980s, there was a plasma-derived vaccine, and there was concern for HIV transmission or other microbial infection transmission with that vaccine. There were no documented cases of this occurring, but this is no longer an issue because all of the vaccines used in the United States are no longer plasma-based, they're all recombinant. There is still global use of plasma-based vaccines, and that has been documented to be quite safe. In 1991, there was new reluctance, well, not new. In 1991, when the original recommendation was issued, there was reluctance about infant vaccination, but with education and outreach, by 1996, this was broadly acceptable for hepatitis B vaccination to be given early to infants. In 1999, there was an emerging concern about the use of thimerosal, a preservative that was included in the early generations of the hepatitis B vaccine. And multiple agencies at that time recommended postponing vaccination until 2 to 6 months for infants who were born to hepatitis B surface antigen negative mothers. So that recommendation did lead to a substantial drop in vaccination coverage, and that wasn't necessarily, that drop in coverage with vaccination for infants early after birth was not actually made up with the vaccination during the time period after that. In the year 2000, there were 2 manufacturers who produced thimerosal-free versions of the vaccines, and all agencies immediately recommended returning to birth vaccination, but there have been gaps in that sort of re-implementation. And while there have been suggestions over the years of a connection of hepatitis B to, for example, multiple sclerosis, there's actually no evidence that there a connection of an adverse outcome of that type, or any type really, exists, including an Institute of Medicine report. So I just went through that because I think, as we watch congressional hearings and the attacks, vocal debate about vaccination coverage, it's important to understand where the recommendations come from. And while it might seem reasonable to say if you don't have hepatitis B surface antigen positivity, an infant does not need the vaccine, we have really great public health data to show that, as with many things, our ability to identify people at highest risk is limited, and that these interventions are safe and very effective. And, in the pre-vaccination era, there were 20,000 children a year who were acquiring hepatitis B, which is not an outcome I think that any of us would be super excited about. So that was just a brief detour there. And so now I'll just talk a little bit about the evidence from IAS on hepatitis B that I was going to highlight, and then I will pause and see, get some comment. So there were 2 studies that I thought were relevant to this. And in particular, the questions here are around when we move away from tenofovir containing regimens. There was an abstract presented at IAS, which I'm not highlighting here, but it looked at the outcomes for people with chronic hepatitis B infection, and outcomes were defined as liver events, so progression of liver disease to end-stage liver disease, cirrhosis, and hepatocellular carcinoma. And for individuals who are on tenofovir-containing HIV regimens, there was like a markedly, this is looking at like a cohort-based study using medical record databases. It's clear that being on tenofovir, including regimens, is highly protective for people with hepatitis B. And so that is sort of an obvious thing, but not one that we've actually had to think very hard about for a long time, because tenofovir has been included in almost every first-line regimen that we would choose, with the exception of dolutegravir, abacavir, 3TC. So as we move to utilization of more 2-drug regimens, including both the nuke-sparing cabrolpivirine, but also dolutegravir 3TC or dolutegravir rilpivirine, just thinking about who we should be careful or mindful about, I think is one of our new requirements. And I think many of us got emails from Randy and Joyce in the last few days about our patients and screening for Hep B immunity, which hopefully they'll comment on when I just go through these 2 studies real quick. So the first I'm going to talk about is a sub-analysis of IMPALA, and I'll get to the design of this in a minute, but this is in regions with high hepatitis B prevalence. So the global prevalence is about 7.6% of people living with HIV have hepatitis B. WHO first-line recommendations include Hep B active drugs, but long-acting cabrolpivirine does not have this activity. And so they're aimed to assess the incidence of Hep B infection and reactivation in a study comparing standard ART with Hep B active drugs versus long-acting ART. So it was an open-label, active control, parallel group non-inferiority trial in 7 sites in Kenya, South Africa, and Uganda. They enrolled adults, a total of 540, with suppressed HIV for equal to or more than 3 months on dolutegravir plus 2 nukes, XTC, so 3TC or FTC plus tenofovir product, without surface antigen positivity or earlier infection, so they excluded core only, without immunity. So core antibody positive, surface antibody negative was excluded. They selected people who had what they considered to be evidence of some trouble with oral ART. This was debated for the primary endpoints actually of the study, which they included 1 HIV RNA greater than 1,000 on oral therapy in the 2 years prior, and lost to follow-up of greater than 4 weeks, which doesn't really seem like you're very lost if you return back at like 5 weeks, or unlinked at more than 3 months after diagnosis. And so the results I was just going to talk about is the sub-analysis of the hepatitis B profile at enrollment and the way that they screened for hepatitis, which in this case was actually with transaminase elevation and clinical symptoms. So what did they find? So low level, very low level in this study of vaccine-related immunity. It just points to our privilege here in the United States. So about 8% at enrollment and 31% with core antibody positivity at screening. The results, they saw 1 incident case of hepatitis B in the cabrolpivirine arm. So this just points to the fact that we've effectively had people on hepatitis B PrEP for many years, and removing that might have some consequences. So and again, they did not screen in like the most sensitive way for hepatitis B. They screened for clinical hepatitis. So they identified 1. They did not detect any clinical reactivation. There were 86 individuals who had core antibody positive and received long-acting ART, but they all had confirmed surface antibody positivity at the time of enrollment. So they would all have been considered immune. And for that population, core and surface positive, this switch seemed to be safe in their study. I'll just also mention that their primary results, which was either staying on like the switch to cabrolpivirine, showed non-inferiority. It was preferred by 94% of the people who switched to injectable. They did have confirmed virologic failure. And so technically there is a higher failure. So just while they confirmed non-inferiority, just to be specific about this, there were 5 virologic failures in the injectable arm, which came out to a rate of about 1.9%, and no failures in the oral ART. So that's their non-inferiority margin was 4%. So they are non-inferior by their pre-specified margin. But it is true that injectable therapy, even with on-time injections, fails in a very small percentage of people. That is extremely reproducible across different studies, I would say. That's around 1%. I mean, I include this with my counseling for all patients who want to start it on injectable, that for reasons we don't fully understand, that injectable therapy fails in a small but clearly documented and fairly consistent proportion of the population. That is around 1 in 100. 5 people in the cabrolpivirine arm actually had viral rebound. Interestingly, they all resuppressed on oral therapy, and 4 of them resuppressed on dolutegravir, XTC, TDF. So despite the fact that we often worry about emergent CAB resistance, in this particular scenario or case, the small handful of people who failed were actually able to resuppress with the first-line integrase-based regimen. And then the other one that sort of looked at this a similar question was the Moderato trial. So this was switching to 2 or 3 drug maintenance. So this was another non-inferiority randomized trial in Western and Central Africa. So their enrollment criteria, HIV RNA less than 50 for more than 2 years on efavirenz XTC TDF or dolutegravir XTC TDF and no active Hep B. The duration of ART was between 9 and 15 years. Median age was around 50, and it was a predominantly female study group with 79%. And the arms were either you switched to dolutegravir 3TC, so a 2-drug regimen with no Hep B active drug, well, not with 3TC, but not like no tenofovir. Switch to atazanavir, ritonavir plus 3TC, again with that same caveat about your Hep B coverage, or continue 3-drug ART. So I'll just mention here, atazanavir, ritonavir plus 3TC is not really a 2-drug combination that we talk about. There's good data for darunavir, ritonavir plus 3TC from the Andes trial, but atazanavir, ritonavir 3TC is not one that we have typically used. In the absence of TDF, you do get higher exposure to atazanavir because TDF reduces the level slightly. So there may be a slightly increased risk of things like hyperbilirubinemia or old-style side effects like atazanavir-based kidney stones. But just putting that aside, it's also, there are some people who need alternatives, and a PI-based alternative is reasonable. I don't know why atazanavir was the choice here. So they're reporting the 96-week outcomes, and they found that dual therapy, which they did a combined analysis, so they looked at dolutegravir 3TC and atazanavir 3TC as a combined analysis, was non-inferior. The efficacy was 95% versus 98% to continue your therapy. There was more weight gain in the 2 versus 3 drug arm and slightly improved renal indices. So this is another piece in the puzzle suggesting that maybe tenofovir, and in particular in combination with efavirenz, has weight suppressive effects as opposed to TAF having weight promoting effects because there was no TAF in the switch arm. An active HBV led to exclusion of 7% of the people screened for entry, so consistent with our global prevalence rate, and they did not observe any reactivation of hepatitis B despite change to a non-Hep B active regimen. So overall, I think the bottom line here is if you have surface antibody positivity, it seems like from these two trials and from other experiences that it's fairly safe to switch. And I thought I'd just pause there and see if anybody had any thoughts or feelings about this data, or and I know also if Joyce or Randy want to talk about the Hep B screening recommendations.
Yeah, thanks so much, Eileen. This is really helpful in this era where we're switching people, to nucleotide side sparing, or, going from 2 nukes to 1 nuke. So the QI that we are doing was conducted with Dr. Chloe Teo's recommendation. So there is a case that we know about here in Baltimore of somebody who was previously surface antibody positive through vaccine, and then was failing on oral therapy, became immunosuppressed, had been on Biktarvy and was switched to cabalpivirine, and ended up having what looks like it was a Hep B reactivation. So, it's grade A recommendation that if you're switching to a nucleotide or side sparing regimen and the person is not known to have active Hep B or history of Hep B, to check Hep B serologies within 3 months prior to the switch, just so that you know if they're protected or not. One of the points that Chloe made is that tenofovir is actually not PrEP. There's no real PrEP because of the way of the pathophysiology of hepatitis B. People there is not actually pre-exposure prophylaxis, but what the tenofovir can do is, help with, obviously, if somebody is infected, not having active hepatitis B, causing disease. So that's one of the points that she made. So when we set up the data search, we tried to identify people who were Hep B, either they never had a Hep B surface antibody, or we pulled people on specific regimens. And I don't want to take up all the time of the rationale for each of these categorizations, but I guess the take-home points are: one, making sure that you know the full extent of somebody's hepatitis B status. So a lot of times we used to not check core in the past, but it's good to know if core is present so that you know that reactivation might be a possibility if somebody becomes immunosuppressed. I think that's one point. And then when you're switching, that sort of checking for people who don't have active Hep B, seeing what their status is within 3 months of switching to like a cabalpivirine. The C3 recommendation that, and then some of this other more detailed of folks that we pulled, these are, there's a C3 recommendation about annual Hep B surface antibody checking in people who had been protected only through vaccination. And then this idea of, some caution with people who are isolated core antibody positive. This all has to do with, again, possibility of infection. We know hepatitis B vaccine protects. So making sure people get the full series and have evidence of immunity. And then the possibility of flare or reactivation is, I think, the one that's more questionable about, both the checking surface antibody annually, first of all, and then some of the other caution. So I have more detail about those 3 categories I sent you all. I'm realizing that this is much more controversial than I, initially realized, but we tried to be thoughtful. We're not saying you have to do that for everybody. We just wanted to make you all aware of your people who are on these dual regimens that don't contain tenofovir. And then you can decide, based on what you know about the patient, how you might want to risk stratify in terms of helping protect them against either Hep B infection or reactivation.
So
I
Joyce,
hope
I
that's
think that,
helpful.
yeah, that's super helpful. And I think that the clarification around like what I was describing as PrEP, but may have been masking, like in terms of like the idea. So I guess I'm not aware, and unfortunately Chloe's not here, but maybe Dave or Ashwin could also comment. Like I was not aware that it's ever been shown that someone has acquired Hep B while on tenofovir, but it sounds like that at least is theoretically possible, but also might have happened. Dave, you're unmuted.
Yeah, I'm happy to. The incidence is lower, but interestingly, it's also true that for persons vaccinated, you occasionally see core conversions
Hmm.
suggesting that they're infected without clinical hepatitis. And
Mm-hmm.
the vaccines are licensed to prevent symptomatic and chronic hepatitis B, not all infections. So it's not as different, but obviously in terms of the pathogenesis, that there is as Chloe said, there's more of a rationale um, for prevention with an antibody than with something that acts several steps downstream after the virus is already in the hepatocyte. So I think, I mean, I'm agreeing with her. And while I'm unmuted,
Yeah.
I would just say that was a great summary. And I do believe that on the positive side, we have very, very encouraging data with the use of Heplisav B in HIV infected individuals, and that 3 doses uniformly produces sky high antibody titers above 1,000 that last for a long time. 2 doses um, give you reliably levels above 100 for most people. And so I think that that's good news. Unfortunately, we don't have yet, that I'm aware of, good data on Heplisav B in persons with isolated core, which
Mm-hmm.
is a study that's been talked about for 10 years, but to my knowledge, not done with Heplisav B. It's been done with the recombinants, but not with Heplisav B. So, but
Yeah,
I think
Dave,
the
exactly.
the practical thing would be to try it anyway. Like, go ahead
Right.
and use it. It's not going to hurt anyone. And if you can get anti-S and sustain it at pretty high levels. And then Joyce's point and the point Ethel's cases suggest also is why with HIV and dialysis are the two situations where there's an indication for continuing to check titers and not trust anamnestic responses, and to boost when they drop below 10. So anyway, I'm muted now.
Yeah, no, don't mute yet because I have one follow-up on that. Because I think the isolated core vaccine question is one that, like, for example, Paul Sachs, who like is my mother duck and I imprint on what he does, he's often said, why do we do that? Like, what is that doing? But I personally have started doing it partially because Chloe's super influential and also because it makes me feel better to see a surface antibody titer rise. But but there is no direct data to say that that helps. Is that correct?
Well,
Like,
it depends. There is, I'm not aware, let me just be clear. I am not aware that it's been done with isolated core with Heplisav B.
mhm.
There have been data done with recombinant vaccinations, and this guy Lionel Piroth in France is the one that sort of publishes a good bit on that, showing that you can convert a variable number of people. Um, it's a little different than Raj Gandhi's earlier study, but there's the truth is somewhere in there. And so some people would recommend vaccinating without evidence that it clinically prevents disease, but or reactivation for that matter, but with evidence that those who get anti-S are probably better off than before when they didn't have anti-S for all what we know, which is not a whole lot. But I maybe somebody else knows a good study showing that. I just know that there have been ones with recombinant that have shown anti-S responses.
I see Sean's got her hand up, and I know Ashwin was taking her name along with Chloe in their paper.
Thanks, Eileen. Yeah, so like Dave, I'm not aware of any studies that show the effectiveness of vaccination in people that are isolated core, but I do know that there's data from the MACs suggesting that a large number of patients, especially people living with HIV who are isolated core because they previously had resolved hepatitis B and have lost detectable levels of antibody. And so that in that setting, clinically, it makes sense that if a person has lost detectable levels of antibody, if you vaccinate them, then you have the anamnestic reaction, and then they will have detectable antibody, which presumably is protective from hepatitis B infection.
And Sean, I think in your paper that Ashwin, with Chloe, that Ashwin had sent out, you did look at whether tenofovir containing regimen versus a lamivudine or emtricitabine containing regimen was different, and it was a small number, but I think three of the people who acquired Hep B were actually on TDF.
Yes.
Yeah.
Yeah. Yeah. Yeah. And, and I think, our reasoning for that is exactly what Dave had mentioned, that, the stage of integration of hepatitis B is much earlier than the reverse transcriptase phase at which tenofovir is acting to prevent ongoing replication, so that it makes sense that patients can get infected, but because they have tenofovir on board, you prevent replication, which may then reduce the likelihood of an ongoing infection that leads to chronic hepatitis B. But we did see evidence of incident hepatitis B in patients that were on tenofovir. They just, yeah.
Yeah. And I mean, I think the anamnestic response is a great rationale for doing the vaccination. I guess the question is, if it's because you have chronic infection, would resurgence of antigen from reactivation of the virus actually have the same impact? And whether or not you can document that maintaining it at high levels actually prevents the clinical consequences if you're presuming that the antigen is there somewhere to emerge from. And I think that's sort of where, like, not to be taking his point, but where Paul's question arises from.
But but if patients are only isolated core, they're surface antigen negative. And so we don't think they have, by definition, they don't have chronic infection, right? You could have the rare case of, what's it called?
Occult.
Where you have,
The pre-core.
occult hepatitis B. Yeah, so occult hepatitis B, where you have infection with a virus that you're not able to detect on our surface antigen assays, but that is very, very rare. I mean, in fact, I think most people that treat hepatitis B, when they see isolated core, do not even bother checking for an HBV DNA, but because it is so unlikely that this is occult hepatitis B. So that if you are just isolated core, I wouldn't consider you as having chronic hepatitis B or having an ongoing infection, right? You were previously infected, but you have an ongoing infection. And so then that's where I think, like you were saying, that benefit of the anamnestic response to vaccination might confer some protection. But again, like Dave was saying, I'm not familiar with studies that have demonstrated that empirically.
Yeah, I'll just pipe in. Sorry, we're out of time. I totally agree with Sean and what Dave said and Andre on the comments. But we have found in livers from alive that were taken from people who were Hep C positive and isolated core positive, that about 30% of the liver biopsy had Hep B, either DNA or RNA. So I agree that it's kind of confusing what our definitions are. But it doesn't seem likely that anyone who's exposed to hepatitis B is truly ever kind of free from
Clear.
genomes. And all we're talking about are relative, like a spectrum, which I think Dave has said in the past, a spectrum of control. And maybe certainly the surface antibody, core antibody folks probably are the best controlled, and maybe the core antibody folks who are isolated, maybe close to them, but not perfectly controlled. But it does seem like there's a spectrum, and the numbers that we found correspond with the likelihood of reactivation after getting CD19 or CD20 anti-CD20 therapy. I'm sorry.
Right. So I apologize to everybody for bringing up such a complex and like rich topic that we could have clearly spent like 2 sessions on. I will just say, I think to me, what the bottom line is that although the probability of some of these outcomes is low, it actually very much mirrors the earlier introduction to infant vaccination, which is the interventions are extremely safe and effective. So we should do them. So Heplisav for everyone, let's check surface antibodies. Overall risk of reactivation with 2-drug therapy seems to be low. And maybe we'll have more hepatitis B if we can lure people back in a, and I won't even say anything, it'll be amazing. But thanks everybody for joining, and have a great weekend. Sorry to go over.
Thank you.
Thank you so much. That was excellent. And it feels like maybe we just do a whole session about this, Eileen, and that might be good to do at some
Yeah.
point.